In India, primarily healthcare financing is mostly individuals who pay directly to healthcare providers.
Why don't we look at the beneficiaries' health profile? Health and wellness clinics are designed for that. But unfortunately, the NHM and NHA don't talk to each other.
When you see the healthcare as a business, the implications are entirely different. Say 5 insurance companies come together and then say, this is the price we are giving you that. Take it or leave it.
To have constant stakeholder engagements and discussions. So companies are also evolving in their products. Suppose I can have a 2 lakhs of basic insurance policy because I cannot pay more. I can have a top of 5 lakhs if it is needed.
In India, primarily healthcare financing is mostly individuals who pay directly to healthcare providers, what we call as out-of-pocket expenditure, OOP. Many of us are aware of this. And there are perils of that model. We'll talk about them. But then also there's an alternative to paying out of pocket, which is insurance. Again, it's a two-step process, right? Insurance, I may pay out of pocket or with the help of an employer. But then who pays the healthcare provider is an institution and not an individual. And again, there may be benefits and pros and cons of that approach. And then we also talked a little bit about managed care, which is another form of financing plus provisioning. And then more and more terms will tumble out, okay? So there's capitation models and this and that, and hopefully we will cover some of these who are below or close to below poverty line already. Some of them were spending money on their own when they went to hospitals. And then we had these various state insurance schemes and now PMJY, which is covering them, right? So if I take Sandhya's argument, one could say, okay, so now you've got some economies of scale. What are the opportunities in that framework, in the current PMJY-like framework, to get the benefits that we think we can get from scale? You know, how can we drive towards better quality, better pricing, you know, reduce unnecessary care, so on and so forth. And I'm asking this because you've done work in multiple states, closely working with the state health authorities who implement that scheme. So if you can share some experiences, whatever has been achieved, but also what can be done going forward and is still undone or let's say unfinished agenda.
Yeah, thanks, Sarang. Since most of them are providers, if I'm a patient, I'm paying out of my pocket. The only way I assure my value is I dump a poor quality consultant, I dump a poor quality lab, or so I change. So I trust, that's the competition, whether the patient is getting a value, but it's only a chance for them. It's a 50-50 chance that they are really getting the right. So when the purchaser becomes large, as a PMJ or a private health insurance or CGHS, that's where they have the negotiating power with reference to the providers. Most of you providers, you only look at the benefit package, pre-authorization, benefit package, and disallowances. Most of the focus, both the insurers as well as the providers, is only on the claims processing. But as the insurer, I'm accountable to the beneficiaries, the policy holders, in the case of private health insurance, and the beneficiaries in the case of public health insurance, whether it's PMJ or Aragyashri. But that awareness was not there in the policymakers, that they are accountable to assure quality to the beneficiaries. It's not just the financial cover. If you look at the universal health coverage definition, it's not just the financial cover to prevent hardships. Financial cover to access sufficient quality health care in an equitable fashion and a dignitable fashion. So these three elements are conveniently ignored by both the providers as well as the insurers. The capitation is 600 rupees per person or 1600 rupees per family or whatever it is. So one of the advice, we are experimenting with SACHIs and PMJ as well, is why don't we look at the beneficiary's health profile? The health and wellness clinics are designed for that. But unfortunately, the NHM and NHA don't talk to each other. So the whole objective of that continuity of care with outpatient care and inpatient care, that is not happening. If it happens, that is as a Ministry of Health, as a finance ministry, will question with this per capita cost which you are spending, what is the outcome?
When you see the healthcare as a business, the implications are entirely different. No doubt, healthcare has to be done on some principles of business. Otherwise,
Correct.
the corporate hospitals cannot survive. There is no P&Ls. There are no the healthcare providers. But end of the day, as Krishna said, this is the only profession or business where dil se is more important than dimag se. Your heart has to be there. Otherwise, you cannot provide. You take any biggest, most successful corporate hospitals in the world, starting from Mayo Clinic. All these people are thoroughly standing on the fundamental bedrock of ethics and professionalism. And nobody has failed who have done ethical practice. So it's a business manager's a misplaced conception that we have to take care of the balance sheet. There is one balance sheet called emotional balance sheet. And that is very important. I am the standing example for that. Because I can tell publicly, when I took up Sunshine Hospitals 12 years, 15 years back, I don't know what is EBITDA means. I just know how to treat the patient. I want to treat the patient better. So I just plunged into that. And I survived just because of the emotional balance sheet, not because of the financial balance sheet. But no doubt, financial balance sheet is very important. But it should, as Krishna said, that governance should be there.
To have constant stakeholder engagements and discussions.
Absolutely.
So companies are also evolving in their products.
Correct.
Suppose I can have a 2 lakhs of basic insurance policy because I cannot pay more. I can have a top of 5 lakhs if it is needed, if it is triggered and all these things.
Correct.
Then there are co-pay methodologies. Like a lot of young people, I told you in the
Yes.
afternoon,
Yes.
one of the incentives or one of the desire that I want to come here is I'll be meeting a lot of young people who are the future of the country. Because they will be driving the future economic scenario and whatever, if it is healthcare system and everything, because they will be the business leaders, they will be, many of them will be engaged as customers also. Like I was telling you, suppose a young person is there. Normally you find a young person unless he becomes 40 or 45, he or she doesn't take insurance. But insurance can be needed at any point of time. But when he takes an insurance, he or she takes an insurance and gets his parents into it, the premium gets substantially reduced. So these are the ways and means. So we have observed. So when more and more young people will be there in insurance also, the premiums will tend to get reduced while providing coverage to all the elderly people also.
I mean, one thing, because you talked about ecosystem evolving over time and tying it back to the out-of-pocket expenditure, because new evidence is suggesting that this out-of-pocket expenditure is not only hospitalization expenditure, a lot of it is outpatient expenditure. Okay, so I mean, many discussions this has come up. We have some insurance products that cover outpatient expenditure, but they're not very good. Any thoughts from IRD? How can we move in that direction?
Evolving scenario, and many of the insurers, they also, because if you'll be surprised to know that they've got tie-up with many of the Ayushman Bharat hospitals. So we call it like preventive, promotive, curative healthcare. So, and it's a win-win situation for both the insurance company and the patient also.
Got it.
Which could have needed hospitalization, maybe a surgery and all these things.
Got it.
At the very early stage, it is preventive.
Again, the mindset of the people should change. Of course, it's an evolving system. I'm very happy. I'm always an optimistic, I'll say glass is half full rather than half empty. We have come a long way, provider-wise, the insurance-wise, the quality of services, the outcomes. We are no doubt evolved a long time. But somehow the patients have stayed back. They still think that complication is the complication provided by you.
Right.
They don't understand the complication is a part of a treatment. Negligence is different from complication is different.
Fair.
And second thing is, whatever the ecosystem, I'll tell you as an example, the people who are going down below the poverty line don't need to, because 80% of these people are insured or provided by the government schemes. But they don't use the government scheme. They want the best in the city. They like to sell the jewelry and go to that guy. Why don't you go to the government hospital and get the treatment done? And again, 50% of the treatments they are getting through corporate hospitals can be done as effectively by a government hospital doctor.